Greetings to you, dear listeners. I'm Justine Katwesige, presenting to you the integration of DHIS2 and climatic data for disease prediction, a case of malaria occurrence in Gulu district, Uganda. This research was done with Peter Nabende, Simon Kasasa, Ronald Senyonga, Mary Nakafero, and John Kisa. Previous research has found prediction models important in assisting public health in evidence-based decision-making. However, here in Uganda, our disease burden estimates are only based on reported cases and rough estimates of seasonal weather changes. Because of reliance on only the reported cases, many times our measures are delayed. For example, we shall wait for the month end or for the weekend to know that in this region we have got 1,000 malaria cases. Yet if we had tried to predict, we could have known that there will be a likely increase in the malaria cases in a particular region and provide the best prevention or control measure before it hits us hard. So because of reliance on only reported cases, we have had several prevention and control mechanisms, but malaria is still the leading cause of our outpatient visits in most of the healthcare facilities. Research found that when you integrate disease data with other sources like weather data, you are likely to unearth some hidden patterns which could help in generating reliable evidence for targeted resources allocation. So we also decided to integrate our locally collected weather data with our malaria cases data to see how best we could predict on the forthcoming number of cases before they actually occur and be able to plan for the best resources that are needed at different times and in different regions of the country. For example, currently when there is a malaria prevention campaign, they will say, let us distribute mosquito nets, and they normally distribute evenly, for example, to all households in a particular region or in every region of the country. Yet the malaria cases increase is not likely to be the same. When they are doing IPT, for example, for children under 5 years, they normally send the same amount of drugs, for example, to health center 2s or health center 3s, but you find that in some areas those drugs are left to expire because they don't have the number of cases. Even for treatment drugs, you find some are left to expire because they did not get the number of cases that was expected. Yet if we had relied on our weather data, we could be able to allocate these resources more evenly and more justly than it is right now. This research was conducted to see if we could establish suitable combinations of weather variables and their time lags for malaria cases occurrence and prediction. And we also wanted to provide both machine learning and statistical predictive models that can be used in future prediction of malaria cases. Why we wanted to look at time lags is because other researchers had pointed to a likelihood of mosquitoes not breeding when the rainfall, for example, when the rainfall actually occurs. When it occurs, the temperatures get so low and the breeding stops. So it is always after the temperatures go high and it is a bit warm, that's when mosquitoes breed more. So we decided to try out the different predictive models using both lagged and unlagged to see which one could predict better. And as we see from the results, the lagged model was a better predictor of malaria cases. This research was a retrospective cross-sectional study. Retrospective means that we got previously collected data, and the study was started in 2018, involving collection and analysis of locally collected data from 2 sources. Our 2 sources included the Ministry of Health, which collects routine data from all patients who visit the health facilities, and this data is aggregated into weekly, monthly, and quarterly reports, which are sent into the Uganda Electronic Health Management Information System, powered by DHIS2. Our weekly malaria cases data are sent into DHIS2 through SMSs, powered by M-Track system. The Uganda Meteorological Authority is the one that gave us the weather data, and for them they collect their data on a daily basis and store it in an Excel spreadsheet. So we got this daily data and aggregated it into weekly data to match the Ministry of Health data, which was already weekly. And our data was pre-processed in Stata version 14.1 and Microsoft Excel to ensure completeness as well as preparation of the data into analyzable integrated data sets. Final analysis was done using Stata and Weka softwares. For us to do research, the School of Public Health requires us to clear with the IRB, and we went ahead and got the clearance from the IRB, and we also sought usage of the data from the 2 sources, and we were allowed to use this data for this research. The 2 weeks lagged interaction model of rainfall, maximum temperature, and relative humidity was found to be a better predictor compared to the unlagged interaction model by 34.18, meaning that it's better to use the lagged model, or we can say that malaria cases of this week, for example, are caused, or we can say malaria cases of this week are happening because of rainfall, temperature, and relative humidity of the 2 weeks ago. Not that malaria cases of this week are happening because of the rainfall and temperature for this week. No, it is the rainfall, the temperature, and relative humidity of the previous 2 weeks that is likely to be causing the malaria cases of this week. We also found that our artificial neural network in Excel found a coefficient of correlation of 0.9, showing that malaria cases and weather factors have a great positive association, and therefore we can conclude that weather factors are a major contributory factor in malaria cases occurrence. And our multi-layer perceptron was found to predict better in later years than in the near future, and when the forecasted predictions were evaluated using our actual 2018 malaria cases data, it was found with an overall of 4.49 difference. This can be explained by the fact that our data was relatively over a short time. We only had data of 2013 to 2017, by the time we started this study in 2018, the year was not yet complete, so we couldn't utilize 2018 data. So after getting our predictive models, we got the available 2018 data, and we ran our multi-layer perceptron, which gave us predicted values, and they only had a difference of 4.49, meaning that this can actually be utilized in predicting the future malaria cases occurrence. Approximately 2,689 malaria cases were seen per week over our research period, and we had a rainfall of 28.15 millimeters with temperatures as high as 31 degrees per week. The minimum and maximum values of malaria cases that were observed during the study period were 468 and 11,459 cases respectively. The rainfall in our reporting period was found to have a minimum and maximum values of 0 millimeters and 163.10 millimeters. Our minimum temperature had values of 19.36 on average, and a minimum value of 15.27 and maximum of 22.62. Maximum temperatures we are found to have an average of 30.68 degrees centigrade, a minimum of 26.72, and a maximum of 36.7 over the reporting period. Our relative humidity at 6 hours was found at 75.4, with a minimum of 34.57 and a maximum of 123.07. And the relative humidity at 12 hours was found at 51.19 on average over the reporting period, with a minimum of 17.43 and a maximum of 151.29. This is a presentation of the Weka Test predictions for targets. As you can closely look at the start, for example, our predicted cases were much lower compared to the actual cases, and as time went by, at the start they kept on varying. Weka gives us high cases, the actual cases are low. Weka gives us low cases, the actual cases are high. It continued learning and learning over time. As it mastered the pattern of the data, it started giving us almost zero difference cases between the actual and the predicted cases. So we believe that if we are to get data of a much longer period, maybe 10 years, 30 years, we could greatly rely on this Weka prediction model to predict the future of our malaria cases in particular regions of our country, which could greatly improve our resource allocation capacities. Instead of just pushing drugs to every health facility, for example, let's send this amount of drugs, let's send this amount of health workers to each level of facility. We could rely on these predictions and allocate these resources more equitably. This study therefore concluded that for us to have a change in malaria cases due to weather, the weather factors like rainfall must have occurred 2 weeks ago, with an increase in maximum temperatures and relative humidity. The inclusion of other contributory parameters in future studies could greatly improve the prediction accuracy of the models, because in these models we have only looked at weather factors, but we could add in the other environmental factors like vegetation, lakes and rivers, and then we could see how they play together to influence the occurrence of not only malaria but also other diseases that are likely to rely on weather changes or other environmental factors. We also think that scaling up this research to utilize the whole national data could greatly improve the accuracy of the predictions. As some of us may be aware, artificial neural networks are data hungry, and with what we gave it, actually it was too little for it to give us real significant and reliable results. We believe that if we scaled up this study and included all the national data, that could be a good vast amount of data for the artificial neural network to actually predict much more accurately than it is doing with this small data that we fed it with. And our Uganda National Meteorological Authority, that is still relying on Excel spreadsheets for its data storage, could actually utilize the DHIS2 infrastructure and create a national database accessible by key stakeholders to encourage data use and maximum utilization, unlike the current practice where data is not accessible by public and some of the researchers or stakeholders that require to use their data are required to part with some amount of money for the data that they need for their different interests. Special thanks go to the High Train Scholarship Program under NOHET that actually funded my studies on the Master of Health Informatics, and they also funded the research in terms of data collection and analysis. I would also like to thank the School of Public Health not only for training me but also for sponsoring me for this conference and ensuring that I actually submit my paper on time. And I would like to thank the Ministry of Health Uganda and the Uganda National Meteorological Authority for providing the data that was much needed for this research to go on. Thank you all. Thank you all.